Ladies and gentlemen, I got 11:30. We ready to get started?
Yeah.
1:30, is it 1:30? I knew I was early. We will get started by first, I'm going to ask Asia to call the roll and a name. If you're here representing that individual, such as Senator Coleman Madison has a different face a little bit this afternoon. If you would, let us know your name and who you're representing, and we'll go from there, okay?
Okay.
Go ahead, Asia.
Senator Albritton,
Greg Albritton, Chairman of the General Fund on the Senate.
Senator Orr, Senator Coleman Madison,
Hi, I'm Kirsten Barnes, the Communications Director, and I'm representing Senator Coleman Madison today.
Excellent.
Representative Reynolds,
Here.
Representative Garrett, Representative Warren, Mr. William Ashmore, Mrs. Dorian Carlton, Miss Jill Cullen, Mr. Marcus Morgan,
Here.
Dr. Eric Mackey,
Here.
Miss Jo Moore, Miss Laurie Morgan.
Lexi Solario here from the State Personnel Department representing Lori Morgan.
Thank y'all. Thank y'all for being here. The plan today is to try to get started. There is a perception, whether it's accurate or not, that we're going to try to find some way to continue or to achieve parity between the two different systems. We have two different systems in Alabama. We've got a general fund, we've got an education fund. Those things have different methodologies, different numbers, different revenue streams, and different purposes. Alabama's unique in this way. That also creates inflexibility and difficulties. Our purpose in this is trying to find the methodology whereby we can maintain and make sure that our employees have the same or close to the same coverages, the same costs, the same benefits as each other have without having one overshadow the other. We see that as a developing issue. Now, my goal, I think our goal, is to make sure that the first thing that does not happen is entrenchment. If you have a shovel in hand, please dispose of it. Picks also. The last thing we need is entrenchments that's going to keep us from moving forward and prevent us from making any headway. What I would encourage you to do is bring an open mind, to bring engagement, and by that I mean positive engagement, because we're not here to help or sustain PHIP or help and sustain SEIB. It is here to help the employees and the people of the state of Alabama in the best way possible. I also state this. This is not a foregone conclusion. We are not here to build a facade so that we can achieve a already designated end. To be more blunt, we're not here to force unification. This is not a shotgun wedding. This is a matter of where we're trying to reach a means together. You guys are the professionals. Many of us here are part-time legislators that have to make decisions based on the facts that we have. Most often we are surrounded and swamped by many ideas brought forward in legislation that may not be completely thought out or understood not just by us, the perpetrators, but by others until we get it completed. We want to be able to have a unified way to approach this, and that's why we're turning to this body, the professionals, to find out what we can do and what we should do, and then figure out how to do it. That's what the goal is here. Timeline, I'd like to have this done before we start dropping bills in February at least. I'd like to have some concepts and ideas of where we're headed, but it's going to take us meeting together often between now and then, and separately. I want an open forum here as much as we can, with together by phone, other means, to work out what we can do, what we should do, and then proceed with the how. So, am I making any sense there? Chairman Reynolds, you have any comments along those lines?
Mr. Chairman, I think I'll follow your lead today and looking forward to listening to the presentation, see if we can, in fact, do anything, or they'll have to stay as they currently are, and certainly look at the impact that the increases. I just read an article yesterday, I guess, in 22, I guess insurance went up less than 1%, and 23 went up 4%. So I'm sure that's been our challenge, and certainly dispersing that over the number of employees under both plans. So looking forward to the conversation. Thanks, sir.
Thank you. I'd like to proceed now. We've got two presentations, I think. We're going to allow first SEIB to move forward with a presentation, and then we'll hear from PHIP. After those two presentations, I'd like for you guys on the body to be thinking about, what do we do now? Where and how do we proceed? What goals should we have? And let's have a few minutes to discuss that, and maybe we'll go from there. All right? If you would, introduce yourself and tell us what you're going to do.
Thank you, Mr. Chairman. Thank you, members of the Commission. My name is Sally Corley. I'm the Chief Operating Officer for the State Employees Insurance Board, commonly called the SEIB. Appreciate the opportunity to stand before you today and help dig into this issue. Health insurance is a very complicated topic, so we're going to try to keep it high level today and meet the challenge of short and simple. The SEIB was created in 1965 to provide health insurance coverage to state employees, retirees, and their dependents. It is governed by an 11-member board. All 5 members of the State Personnel Board serve by virtue of their position on the SEIB board. We have 2 active employee members, 2 retiree members, and 2 ex officio members, the CEO of RSA and the finance director. We offer a medical plan, a prescription drug plan, standalone coverages, which are dental, vision, and cancer. We also offer supplemental and optional plans in lieu of medical coverage. This is our vision statement and our mission statement. We have an operational plan. It's a dashboard of goals and objectives with over 70 key performance indicators that feed into that measurement. We also have a strategic plan. That's our roadmap on how we're going to achieve these goals. I'll give you a glimpse into what the SEIB is working on right now. It's been a very busy season for us. This is one of 3 legislative committees that we're currently participating in. We also have all 3 of our major contracts are up for renewal right now. We're working through the RFP process. The first one is our medical contract that's currently held by Blue Cross Blue Shield of Alabama. We have our pharmacy benefit manager contract, or our PBM contract, currently held by Optum Rx, and our Medicare Advantage prescription drug plan, currently held by United Healthcare. Let's start by talking about innovation. Our board, our agency, and even the legislature has partnered with us on being forward-thinking to implement some cost-saving measures that have helped keep the costs down for the members, for our plan, which in turn saves money for the state, and more specifically the general fund, because we are a general fund agency. This slide shows just a snapshot of some of the highlights of our last 20 years of innovations. Start in the bottom left. In 2004, there was a legislative special session that focused solely on employee health insurance benefits. As a result of that 5-day special session, we are able to offer the retiree sliding scale premium and also the supplemental and optional coverages, which we just talked about in the previous slide. In 2005, we were the 2nd plan in the nation to implement a non-tobacco user discount. In 2009, we were the first state plan in the nation to implement a wellness discount. Now, this one made national news, and we're thankful that Alabama was in national news in a positive light. These two, the tobacco discount and the wellness discount, are examples of how we strive to find ways to help improve the quality of life for our members and also create savings for our plan. It's far cheaper to cover healthy members than otherwise, and we want to find ways to encourage healthy choices among our members. In 2011, the legislature again revisited the retiree sliding scale. We clarified the formula to determine the sliding scale premium. In 2015, we were the first plan, again, to implement a program that maximizes manufacturer coupons for retail drugs. In 2022, we expanded that to also include medical drugs. Let's talk about enrollment. So you can see on this chart, we have chosen the years 2010 to 2023. We've chosen this 14-year period intentionally. In 2010, that was a high water mark for us for the number of full-time state employees, but you'll see the same time frame carried throughout our presentation. So we cover over 100,000 lives, right at 100,000 lives. But you can see that black line across the top represents the number of households. So in 2010, the SEIB covered about 56,000 households. You can see in 2023, we still covered right at 56,000 households. Now let's drop down to the blue line. That represents the number of full-time employees. In 2010, we were at the high water mark of 37,000 full-time employees. In 2023, that number dropped down to 31,000. You can see that during this time frame, while we're covering the same number of lives, our population is changing dramatically. In the orange, you can see that represents the retirees. So we went from 19,000 in 2010 all the way up to 25,000 in 2023. Now, this has an impact to our plan in two ways. It impacts our cost, and it also impacts our funding. All right, this slide, it looks like the dashboard of your car, and that's intentional. These are the key factors we use in managing our plan, and as you can see, they're all in the red right now. That sets off warnings for us. So let's walk through each one of these and let me explain to you why these are important to us. On the far left, you start with the active employee ratio. That's what we just saw on the previous slide. Our active employee ratio is down by 10.5 percentage points from 2010 all the way to 23. That has an impact to our state funding rate of $150 per full-time employee per month. Now let's look at the average age. In 2023, our population's average age was 38.4 years old. An average age of 36 is normal. Now why is that important? As our bodies age, our bodies change, and we tend to be more inclined to high-cost claims. So that in turn, the higher your average age, it stands to follow the higher your risk score will be. Our risk score in 2023 was 1.12. A risk score of 1.0 is average. That alone impacts our state funding rate over $100 per full-time employee per month. So you take all of these together, if we had an active employee ratio of 66% as we did in 2010, and we had a risk score of 1.0, you could shave over $250 off of our state rate today. Now let's talk about the state rate. I know I've been referencing that, but I haven't fully unpacked that. What is the state rate? It is not the cost to cover a state employee. That is a common misconception. Our state rate is a funding mechanism that is part of the formula that determines the total state funding that the SEIB receives from the state. So look at this blue box down in the bottom right. You can see in 2010, we had a state rate of $805 and received about $362 million in total state funding. In 2023, the state rate went up from $805 to $930, but our state funding overall went down to $344 million. What caused that? It's based on the number of full-time employees. So focusing on the state rate only focuses on part of the equation. We need to look at the whole equation to see our total state funding to get a complete picture. Let's look at the bar graph on the left. You can see that over the last 14 years, remember I told you we chose this time frame intentionally. This shows you that we've received almost level funding over the last 14 years. The orange is the part that the state has contributed. And the blue lines on the bottom, you can see there's a steady increase in the part that the employees have contributed. Their out-of-pocket expenses have increased during the same time frame. All right, let's talk about cost. So the cost of healthcare is going up. And I know that we have had a lot of conversation about this, but for the benefit of the group, I want to be sure to unpack this. We have some high cost on the horizon. Our Medicare Advantage plan, remember I talked about those RFPs. Our initial proposals show that our Medicare Advantage plan will more than double in cost for 2025. That is alarming to us. Combine that with the blockbuster drugs that are already on the market or coming new to market soon, there's some very high price tags associated with that. So yes, our costs are going up. However, this trend right here, again, same time frame of those 14 years, shows a less than 1% average trend. How are we able to do that? Remember those innovations we talked about early on? We add those innovations on top of our cost, and it smooths our trend out overall. Let's unpack this even more. In 2023, the SEIB spent $475 million. Let's start at the bottom. 4.3% of that total went to pay our third-party administrators. Remember those big contracts I was talking about? For our medical contract, for our PBM contract, those fit in that box right there. $5.5 million is what we spent to fund the operations of our agency in 2023. Now, what about the balance of that $475 million? There's $455 we haven't talked about yet. All of that $455 million went to pay healthcare providers, hospitals, physicians, pharmacists, Medicare Advantage, dentists. Let's unpack it even more. This is how that money was spent in the state of Alabama in 2023. It's broken down by county. I apologize, I know it's small to see. I'll be glad to provide you with an enlarged picture if you would like. But keep in mind, almost 96 cents of every dollar the SEIB spends goes directly to these healthcare providers in our state. Let's talk about benefits. So I handed out a single sheet. It should look like this. It is a quick reference guide. It is a high-level overview of the benefits that we offer to state employees. I know you said to keep it high level. We'll be glad to unpack this in the future if we need to. But these are the benefits we offer all state employees on day one when they start. How do we compare? That's something we've talked about. So the state of South Carolina conducts an annual 50-state survey. Based on that survey, the SEIB is 12% below southeastern states in cost. However, we're 4.4% higher in actuarial value. Well, what does that mean? That's a lot of fancy numbers. It means that we offer a better benefit at a lower cost than our sister southeastern states. How do we compare on the national average? The Kaiser Family Foundation conducts another national employer survey, and it shows that we are 18% below the national average on cost. So before I leave the slide and go to questions, I just want to wrap up for you a few points that I want you to take home after I leave today. Our state rate has changed, and there's been a lot of conversation about our state rate changing. However, we've been almost level funded for the last 14 years. In that same time frame, our population has changed, which in turn has pushed our dashboard into the red. We're very concerned about that. The cost of healthcare is rising. We have some alarming costs on the horizon. We're concerned that no amount of innovation is going to be able to smooth over these future costs. We work hard at the SEIB to be good stewards of the state's money. We understand the importance of offering a good benefit at a low cost to the member and also a low cost to the state. And we want to continue to be an important part of the package that recruits and retains state employees. Are there any questions?
I've got a couple, if I may, Sally. Now, I'm looking at your handout that we have and going a couple of pages beyond what you're showing on the screen.
Yes, sir.
It shows carry forward.
Yes.
past years, and then it shows COVID relief funds there in 2021, 22, and 23. Can you address that a little bit and tell us what's going on there?
Absolutely. I'm glad you asked about that. So we titled this slide Carry Forward. We've gone back and forth with the budget office. There's a bit of a terminology gap we had there. Internally, we call it net position, fund balance, but we've determined we're going to call it Carry Forward going forward. This fund is, or it also can be called a reserve account. It is the difference between your assets and liabilities. We use all of this money to pay benefits. You can see that it is healthy to have a little bit of carry forward because you never know what a year's going to hold. You can see in 2020 and 2021, and it goes forward from there, that is where the COVID-19 relief funds came in. So that's your ARPA money, your CARES Act money. That has had a significant role in helping keep us afloat. You can see that if we did not have those dollars in 2023, our carry forward balance would have been extremely low.
COVID money is to be spent within the next, where are we? 16, 17 months. It will be gone, either spent here or taken back. How will that affect SEIB? Not having COVID money.
Fully appreciate you asking that question. As you can see, that goes to the heart of the matter of what we're concerned about here as I stand before you today. Our funding is not growing at the pace that our costs have been growing for many factors, and we are running out of reserve to be able to bridge that gap. So at some point, we're going to fall off a cliff.
So you've been spending, that's too strong of a term. So reserves that you've had are being expended in order to cover some of the gaps. Is that accurate?
You're saying, would you mind rephrasing that?
I don't know if I can. So you've had reserves, but in order to keep costs to members lower, you've been expending the reserves to
Yes,
cover
sir.
that. Is that accurate?
Yes, sir, that's accurate. We have used this, sorry for the feedback. We have used this reserve fund to bridge the gap.
Okay. Any other questions from anybody?
Yeah,
Dr. Mackey.
Just looking at 20, of course, we know there was a pandemic in 20 and 21, but is there a reason why you had the reserve got pretty healthy those 2 years other than the COVID funds on top?
Yes, so the 2020, you'll recall, that's the year that the world shut down. So a lot of your doctor's offices shut down as well. We did not spend as much in claims, but then there's been a correction. But
Right.
we've leveled off from that correction since then.
Good explanation. Thank you very much.
Good question.
So in essence, to clarify that for a moment, in 2020, you're suggesting that the use declined
Yes, sir.
by members, which
Yes, sir.
which reduced the expenditures there, correct?
It was a brief reduction because there was a correction, if not an overcorrection, in the subsequent years. So
All
you
right.
had some delayed diagnoses.
Chairman Reynolds.
thank you. Sally, if I'm looking at this chart right, so between 2010 and 2023, so the employee saw a $22.10 increase over that period of time. Is that accurate?
He's looking, what chart are you looking at, Chairman?
The orange and blue one.
The premiums,
Yeah.
to the premium
On the
slide.
premiums.
Thank you.
Is that right? Am I looking at that right? Based on the 73.50 and the 95.60? Is that showing the premium increase for the employee?
That the math does seem to add up to
Oh,
that.
okay,
Yes, sir.
Okay. And then if my math is right, so 6,176 less employees. Is that accurate? From 2010 to 2023?
Yes, sir.
Okay. I don't know, Lexi, this may be for you. I mean, how are we looking today, 2024? I know that corrections and Aaliyah both have had great strides in hiring lately.
I think that we're doing a lot of stuff internally that I think that have affected agencies as a whole. Obviously, I know we're still below that number that we saw in 2010, but I think the registers are getting healthier. I think we're getting more people that are interested in state employment
Okay.
overall.
So 24 enrollment, do we see any increase, some increase? Yes, sir.
Defer to my boss.
Okay.
Use your mic, if you don't mind, sir.
Ever since January 2023, we have seen a steady increase in the enrollment. Now, it's not a large increase, and it's not making up for all that we've lost in past years. But we are seeing between 70 to 90 employees per month being added to the enrollment each and every month.
Very good. Thank you.
It's certainly a good positive.
Great. Thank you.
Marcus?
Yeah, just a couple questions, just so I understand this carry forward balance. But what is a healthy carry forward balance, and do you budget for that with your state rate?
So we are an agency of lawyers and accountants. I'm a lawyer, so I'm going to defer to our top accountant.
William, if you would push your button there on your mic. There you go.
All right. There's a couple reserves that we need to describe here. One of them is on the balance sheet. That would be an IBNR reserve. It's claims incurred but not reported. Those are for claims that folks have already gone out there and they've encountered the expense. We just haven't received the bill, okay? So we've got all that taken care of. It's on the balance sheet. So if we were to close down today, that's taken care of. The balances that you see on this page is what's in excess over, and I use the word excess, and be careful when we use that, but that's the amount that's over the amount that we need for the IBNR, okay? When we do our projections, and we will give state agencies, we'll tell the budget office to tell all the state agencies to budget a number. We're putting that number out well in advance of that fiscal year ever happening. So like if we're putting a number out today, that fiscal year starts a year from now and won't end for almost basically 2 years from now. So if the claims come in less than what the funds that were coming in, you will see that reserve go up. Now, the question would be, is there a policy on, how much reserve you want to maintain? You want to pretty much try to keep at least, 1 month to a month and a half, because anything can happen, okay? But when you're going so far in advance, it is hard to hit those type of targets. So some years you will have more come in, but then likewise, you'll have some years, just like the COVID years, where you can just throw everything out the window. The claims turned out to be very low that year, and the reserve went way up. But then there's other times where you miss it the other way.
And then just a follow-up question to the number of employees. Now, looking at the 31,000, I think it was 31,032. Is that all state employees? So when I compare that number to, say, a number that personnel puts out and says these are the number of employees that they have at the end of the year in their annual report, those numbers don't necessarily jive. So can you explain the makeup of that 31,000?
Excellent question. So this is based on the number of full-time employees. So our funding is based on the number of full-time employees per month times the state rate. So what you may see from state personnel, I would guess, and forgive me for guessing, but I think it would include all employees. So your retirees returning to work, your part-time employees, any combination thereof. I also know that there's a further difference between the two, in that we also have some checkbook agencies that are bank outside of the comptroller system that we also deal with. So there's always going to be a difference there, and it's easily accounted for as we do frequently reconcile to make sure that we are still tracking the same.
Any other questions? Let me then cut to the chase real quick here, all right? Looking at some of these things, and you've got another slide here, the sustainability.
Yeah.
Okay, that you've got. My question is, where are we on that chart actually? Where is SEIB? Are we sustainable, and for how long? Since we're expending our reserves, how long can that last, and where's the, where are those two lines, not those two, but where are the crossing point, the drop dead date, if you will?
This chart shows, in the blue line, shows the growth of the general fund, again from our time frame of 2010, and this one goes to 2024. So you can see the general fund has grown 65%, which we're very thankful for that. Several governors ago, our agency was challenged with marking our sustainability as benchmarked off the growth of the general fund. So that's why we have this slide. You can see that the SEIB has not grown at the same rate that the general fund has grown.
So are we in danger or not?
Let me answer that. 'Cause I've got
Yes.
numbers here again. This is Mike's. Okay. We are, we can still use some of that carry forward, okay? Now, the danger of using too much carry forward is what we call loss ratio, basically meaning your claims get greater than your revenues that are coming in. And if you're using reserve to bridge that gap and it gets too large of a gap, then you've got some serious problems, okay? But right now, looking at our forecast for instance, fiscal year 25, and you've already given us the state rate for 2025, but it's projected that we will end up somewhere in the neighborhood of about a $20 million loss, okay? We have enough reserves to make it through that year. But then when you look at fiscal year 26, that loss jumps up to about $37, $38 million, and all those reserves will be gone. So we're at a point where you have to start addressing, you know, are we going to do any of it, changes on the funding side of it, or are we looking at having to make complete changes on the expense side? And
to make sure everyone's clear on where we are, we have the 25 budget that's passed this past a few months ago, and the upcoming budget that we'll be dealing with is 26 year, which is the budget year that you're speaking of that will be a problem, possibly.
Possibly. It's when you come out of that fiscal year 26, what we're projecting right now is a loss ratio, and I know a lot of this won't make sense to many folks, but we're getting up there to where the loss ratio is 1.08, meaning that your expenses are 8% higher. And when all those reserves are gone, you're still going to have inflation to deal with, plus you've got this big gap of 8% you've got to deal with.
Plus no COVID money.
There's no COVID money. And so that's, you know.
And then whatever the economy does.
And whatever the economy. And so, you know, what I would certainly encourage, you know, if we look at some type of strategy around, you know, how do you abate, you know, that cliff, you know, doing a little bit each year is what we've tried to look at.
Thank you. Any other questions?
Just a comment, Mr.
Yes,
Chairman,
Mr. Chairman.
and I think we've kind of begun that in the 25 budget, or that's what we attempted to accomplish anyway. But I think we got to continue this dialogue. We can't get this wrong. I mean, with a declining workforce out here and our ability to recruit state employees, we absolutely have to get this right, and we absolutely need to be a year or two ahead of the problem. I mean,
Which is why we're here.
That's right. That's right. But I just you know, we appreciate open dialogue about it. Let's try to look at these numbers, try to get our projections right, at least during a time that we do have additional funding in the general fund. So thank you for that.
Thank you, Sally.
Thank you.
Pia.
Good afternoon, Mr. Chairman, members of the Commission. My name is Dave Wales. I'm the Director of PHIP, or the Public Education Employees Health Insurance Plan. I have similar content to present to you today regarding PHIP. Before we dive into it, I'll give you a quick roadmap of what we'll talk about. We'll talk about the construction of PHIP, the build of PHIP, what it is. We'll look at then more of the business model, the funding side, the expense side, and then I'll have opportunity for questions. But please, anytime during my comments, if you need more clarification or have a question, please don't hesitate. So let's jump into it. And we'll start on slide 2. And we'll start by looking at how PHIP was built and what it provides and who it provides it to. So it was created in 1983 to provide uniform health insurance benefits to active and retired public education employees. Insurance products that we offer, we have a hospital medical plan that is self-insured, that is our biggest product. We have 2 other hospital medical plans, one of them being a supplemental hospital medical plan that pays the copays deductibles of other primary coverage. We have 4 optional plans: cancer, dental, vision, and indemnity. We have flexible spending account plans where our members will set aside their income pre-tax to pay for out-of-pocket expenses that they may have during the year. Across all these products, we've got over 355,000 people enrolled in one or more of our plans. And by statute, we're governed by the same board as the teachers' retirement system. Speaking of that TRS and PHIP board, there's 15 members. 3 are ex officio, the state treasurer, finance director, and state superintendent of education. The remaining 12 are elected, 2 from higher education, 1 from post-secondary, 1 school superintendent, 1 school principal, 3 active teachers, 2 support personnel, and 2 retired employees. So that covers what PHIP is. Now let's talk about who we provide it to. And if we look at slide 4, and we think about those 355,000 members, the folks that are eligible for that come out of 3 buckets. So active employees are employees of K through 12 schools and community colleges, and then agencies or employers that participate in TRS that have also elected to participate in PHIP. The retirees of those same organizations, but also from public universities like Auburn, Alabama. And then the dependents of each. So the spouses and the children up to age 26, and then the children over 26 who have been evaluated as incapacitated by a medical professional. So let's take a quick look at how those members spread across our hospital medical coverage. And what you see on slide 5 is a breakdown of the contracts between active and retired, non-Medicare eligible retired and Medicare eligible retired, and then what that translates to in terms of total covered lives. If you look at the active population, 86,263 contracts. For non-Medicare eligible retirees, these are retirees that are generally less than 65, 9,111 contracts. Together, those subscribers translate to 227,604 members, which is part of our self-insured hospital medical plan, which I said is our biggest insurance product. For Medicare eligibles, that's a separate hospital medical plan. It's a fully insured plan that is administered by United Healthcare, that we pay more or less a subscription fee to them to deliver that health insurance product to those members. We've got 60,063 contracts, meaning 79,623 covered lives. So that wraps up a look at the build of PHIP. Now let's shift gears a bit and talk about the business model. And that business model simply being plan management with the goal that expenses are less than revenue. So we'll dive deeper into revenue first before looking at expenses. Talking about revenue, PHIP funding is funded primarily by employer contributions and member premiums. We'll look at it graphically here in a second that represents the split of those. But the employer contribution, or the total employer cost, is a rate that is set by the legislature annually. So this rate, multiplied by the number of active employees that are eligible for PHIP, multiplied by 12 months in the year, translates to our total employer cost. That's the biggest bulk of our funding. That rate is a flat amount that has been calculated at $800 per month since 2017. We'll next take a look at a visual that illustrates these funded sources. So you can see that the employer contribution, being the biggest chunk of the pie for fiscal year 23, was $987 million. The member contribution there in light green being the next sizable part of this at $388 million. So that employer contribution representing about 64% of funding coming into PHIP. Other funding sources that you'll see on here include some investment income, some money from a federal program called the Employer Group Waiver Program. The university, four-year universities, deliver the funding to us that covers the cost of their retirees that we cover. And then coronavirus relief money that's already been spent by PHIP that was to offset the claims for testing and treatment of COVID-19. Another thing about that $800 per month funding driver employer rate is that it goes to subsidize nearly all PHIP programs and operations. So it subsidizes the active employees, the retirees, the dependents, and the administrative expenses. But let's look again at the 800 and let's see what it sums up to in total dollars. So we'll look at slide 9, which breaks down that 800 over a 3-year period and shows you what the rate translates into you in total dollars, and also gives you an idea of what that means coming out of the Education Trust Fund. So you can see over this 3-year period, fiscal year 23 to 25, the $800 goes from $987.4 million in 23 to almost $1 billion in 25. Underneath that, you see the share from the Education Trust Fund, $703.7 million in 23, $709.8 million in 25. So that's legislative and employer funding. Let's look at the second biggest piece of PHIP funding, which was member contributions or member premiums, and that's on slide 10. So these are the premiums that our members pay. An individual active will pay $30 per month for their PHIP coverage if they're enrolled in a hospital medical plan. If they have dependent children with them, they'll pay $207 a month. If they have a spouse only, $282 a month. And if they have spouse and children, $307 a month premium. A couple of notes about these is that these are the base rates. They are subject to a $50 additional wellness premium on top of it if they don't get a wellness screening annually as part of our wellness program. They're also subject to a $50 tobacco surcharge if they don't certify to the plan that they've been a non-tobacco user. All right? So now that we've looked at these funding sources, let's look at the confluence of them over time, which is shown on slide 11. So there's a lot of data here. The top orange line indicates the employer rate set by the legislature, and you can see it from 2010 to 2024. That translates into the blue line of total employer cost in millions from the same time period, 2010 to 2024. The other funding line on here, the green line, the member premiums for the same time period. And that brings us back to the idea of this business model that you want revenue to be more than expense. So in short, you want green plus blue to be more than red.
Dave, before you move from that, can I
Yes, sir.
address something? Go back to that, to your slide 11 there. Thank you. I'm a simple guy. I looked through some of this stuff, and correct me if I'm wrong, but if I took the green line, which is the member premiums, and the blue line, which is employer contribution, that would give us the amount of revenue coming into the PHIP, roughly. And then I took and looked at the red line, which is the expenditures, to make a comparison. I don't know if this is accurate or not, but in looking through this, out of this time frame, 80% of that time frame, the red line exceeded the summation of the blue and the green line, meaning that we're spending more than we're getting in the premium and contribution. Am I accurate in doing that simple math?
So the red and the green line here represent the bulk of funding. There are some additional funding sources coming into PHIP that would make up.
That's from that slide there showing the
Yes, sir.
investments and other matters, right?
Yes, sir.
Okay. So this does not reflect a matter of where you may be expending reserve funds.
No, sir.
Okay, just want
No,
to be
we have
clarified.
not spent reserve funds at this time. We are projecting to do so in fiscal year 25, but currently we are not doing so.
Thank you. Appreciate that.
All right, so before we get into the expense side of it, I want to call out something that runs alongside all of this, which is the Alabama Retired Education Employees Healthcare Trust Fund. So the Retiree Trust was created by statute in 2007 to pre-fund healthcare dollars and help pay for the unfunded liability of the plan. Into fiscal year 23, it had $1.889 billion. The Retiree Trust has been funded by 2 transfers from PHIP, one in 2007, one in 2008, totaling $631 million, received federal monies from 2007 to 14, and also, of course, grows with investment income. The legislature created the trust but does not appropriate money to this trust, and no member money has been placed in this trust. In terms of distributions, monies have been pulled out of it twice, once in 2015, once in 2016. 2015, $92 million, 2016, $32 million to address funding shortfalls and challenges during those time periods. The last note about distributions from this trust is that per Alabama law, they can only be used to pay for retiree healthcare expenses, and they're capped at 10% of the fair market value of the trust. Okay, so the last thing that I would like to cover before, of course, if you have additional questions, is on slide 13, which looks at the opposite side of the pie chart we looked at earlier. So this is on cost. And if you look at fiscal year 23, those costs totaled $1.444 billion. And you can see that the biggest component of our cost being represented by our hospital medical claim expense. So these are the dollars that we pay hospitals, doctors, rehab facilities, infusion centers, diagnostic centers, so on and so forth, representing 70% of our expenses. The difficult thing about the hospital medical expense is that it's most analogous to a fixed cost. While it's our biggest expense, it's our most static expense, it's our most difficult to manage expense. Opposite of that is the green pie chart here, which represents prescription drugs of 17.58% of our expenses. This is where we have the most tools for plan management. This is where we can make the most impact, and therefore this is where we spend our most time in managing the plan. It's the most volatile. It represents our greatest opportunity and also our greatest threat to the plan. So let's pivot from looking at a percent of total cost to looking at real dollars. Slide 14 breaks it down to per member per month. Per member per month is a metric that we like to look at because it lets us know what are each one of these insurance products costing us per person per month. You can see the numbers going across the different insurance programs that we have. One thing to point out is that the denominator changes as you look at different products, and it needs to do so you can evaluate the cost of those accurately. If you look at the first line, hospital medical, at $375.46, this is what any person who's enrolled in our hospital medical program cost us on average per member per month. There's about 227,000 people that are in that denominator to get to that number. If you look right below that, the supplemental plan, this is again where we pay the copays, deductibles for somebody who takes other coverage, not PHIP. $57.42 is divided by a much smaller number of people because a far smaller number of people enroll in that supplemental plan than do in the PHIP primary hospital medical plan. Pharmaceutical cost at $94.69. The other one that I would call out here, the flexible spending account of $142.76. That's not a PHIP expense. That's the average of dollars that members have set aside from their payroll, from their salary, for flex deferrals to pay for their out-of-pocket healthcare expenses that they may have during the year. So that's the PMPM. Another note about this before we move forward is that this does include the admin fees that we pay to the providers of these. And that looks at cost as it is today. So I want to conclude by looking at cost as it moves over time, which in short, it goes up. And so you can see going back to 2003 all the way to projected 2027, how our total medical and pharmaceutical costs have behaved over that time period. There's ebbs and flows on this that correlate with rather sizable changes in plan design or in plan management strategy to influence this curve. When we look at the tail end, you see the sharper increase. It's for a couple of reasons. One, it's when we look at the tail end projection, it's always a sharp increase because our projections are conservative. No actions have been taken yet on the future. We're not there yet. So it's always higher than what you've seen historically. Also, we have increases coming our way from Medicare Advantage plan due to changes from the federal government. It's going to be difficult to manage, but this is where we have been since 2003, and these are the projections that we're going forward, again, without intervention from plan management at that time. So that wraps up my comments. I'm happy to go over anything in further detail or answer.
No questions. I had my question, I think, pretty well answered. Let's go to the cut to the chase, if I will, to get to where are we here? I mean, is PHIP okay? Are we going to be okay? I mean, we looked at SEIB a little bit ago, and we're looking at 26 as being maybe some possible issues. How's PHIP looking in 26 and 27?
So I can tell you from our most recent projections, fiscal year 25 is the first year that we start to access the reserve funds to pay for current year expenses, healthcare expenses. So as you start in 25,
that's in the budget starting October 1st, correct?
that is for fiscal year 25, yes, sir.
Okay.
So going forward from there, it gets more difficult. There are a couple of things that are big question marks. We have to update our procurements this coming spring. That'll bring new contracts that'll bring a new contract for our Medicare Advantage plan this coming spring. That'll be a big question mark in terms of how that shakes out to total plan liability in our net position. But in general, we are very good today, and we are beginning more difficult financial challenges in the future. But I don't think that we at PHIP would cause for panic at this point.
No cause for panic. Good answer.
Yes, sir.
Any other questions, comments? Dr. Mackey.
Okay. Thank you, Dave. I wonder, and I don't want to, so we got two different, no complaint on this, but we got two different kinds of charts. So I'm going to go back to one of CIB's charts and just ask. So I did like the way they did this carry forward chart and talked about where the reserve fund had gone up and down, and then they added the blue bar for the ESSER. And I know, fair disclosure, because I serve on the PHIP board. So I know PHIP's also spent ESSER funds, and those are running out quickly. But is the reserve, so there's no, other than the ESSER funds replenishing, there wouldn't be any orange bars here any years we've had to dip in the reserve, except for the retiree trust. I know you mentioned that.
Right, yes, sir. So the retiree trust in 2015 and 16, we're not currently getting into our unrestricted funds, which is a bit different than our required 8% reserve. That's funded every year and built into it. Let me ask Diane, has there been a period in time where we have spent the unrestricted funds before today, perhaps in 15 and 16? So it would correlate with the same time period.
Okay. Yeah, thank you. Thank you, Mr. Chairman.
Thank you. Marcus, do you have a question?
Yeah, I think I just confirmed this with Dr. Mackey, so excuse my inexperience with the insurance here, but public universities pay for their own employees while they're employed with the university, and then they transfer over to PHIP when they retire.
Yes, sir, that's correct.
And then what I just confirmed is they have to pay a fee?
They pay the cost of what their retirees are to PHIP. So it's a swap out, a wash between the claim cost to PHIP and then the funding coming from the university for that additional cost.
And it is a wash? I mean, it covers everything that I'm just curious about the transferring an older population to PHIP and then y'all estimating out what those costs are going to be. So they get a bill for at the end of or at some point they get a bill?
They do, and it fluctuates a little bit every year and is sent out to them throughout the year. Yes, sir.
Okay, thank you.
Mr. Chairman, quick question. Yes, go ahead. And just correct me if I'm wrong, because I very well may be wrong. So during the same time period, and I'm looking at your language, employer contribution, if I go back to SEIB, it's the state share. So we have increased over that same time period $89 per month on the employer contribution. But yet during the same time period on SEIB, we've actually gone down $174. Is that accurate? Am I comparing apples to apples?
I'm not as familiar with the SEIB employer contribution, but in terms of PHIP, if you look back at slide 11, which I'll bring up here, if you'll bear with me for one moment. Our rate has gone from $752 in 2010 to $800 starting in 2017. Gross dollars, what that means is represented by the blue line, $912 million in 2010, up to around $1 billion currently.
I guess that's the point I'm trying to make. You know, we are increasing state funding on the PHIP side, but we've actually decreased on the SEIB side.
So the formula is the same formula. It's the number of active employees that are eligible for the plan times 12 months times whatever the rate is.
Okay.
For PHIP, it has resulted from 2017 of the same rate to a higher dollar today as opposed to 2017, which means more active employees eligible for the plan.
Okay, thank you.
Sally, you agree with that? Yes, sir. Okay. Any other questions? No? Thank you. Thank you for the presentations. Very
Thank you,
helpful.
sir.
At this point, if I might, like I stated before, I'd like to move into an open discussion as to where and how we proceed from here. I think from the numbers that we've been given, we're seeing that right now we seem to be in fairly decent shape. 25 is set. We know where we are at that point, but at that is going to be the beginning of potential of the unknown, if I might say it that way. And 26 looks to be problematic. So where do we go from here? How do we deal with those issues that are there, and how can we use these two entities to make them both stronger and to provide better services for more efficient cost? How about that? Is there a way we can do that? I'll open up for any comments at this point from the body. None. Is that right? Everybody thinks we're hunky-dory?
Mr. Chairman,
Dr. Mackey, go ahead.
I wouldn't put this on these two today, but maybe for a future meeting. It'd be interesting, and I know some of it because, again, I'm on the PHIP board, and I'm covered by SEIB, so I need to disclose that. But I don't, even in that position, I don't quite understand the differences in coverages. It might be nice if they could kind of do a chart for us and show the differences in what coverages there are for state employees versus the public education employees and the discounts. I know they both offer like a tobacco discount, but what those discounts are and kind of just how they compare to each other
Good point.
would be interesting to have.
Coverages and discounts as to the similarities between the two?
Yes, sir.
Or the differences?
Yes.
Okay. All right. All right. What else should we be able to look at? Is there any differences in payments or contracts with the providers between the two? I don't know if that's the case. I mean, do we have a different contract that says SEIB paid differently to the hospital than PHIP?
I'll address that. There are, most of the contracts are the same in terms of we both have Blue Cross, so what we pay the hospitals are going to be the same contracted rates. The physician networks are going to be the same. On the pharmacy side of it, we both are working with major PBMs, but they are different PBMs. Okay. Now we're also in the process of a bid process as we speak. So all that could change. As far as
now, while you're on that, if I might, so is there a possibility we could get economies to scale if we did a combined negotiation rather than separate?
You know, I mean, that's been looked at, and there are some economies of scale potentially. You know, what we've got in the state between the two programs, and Joe, you can certainly chime in, but through the years, there has been a very healthy competition that takes place between these two programs. There's a lot of innovation that takes place between these two programs, and I say that not just trying to toot our horn. You can look out there to see what other states are doing. And most of them are not doing the things that we do. You look at our costs are well below everybody else's. Our trends have been exceptional. I mean, healthcare has been going up at a rate of about 5, 6, 7%, depending on where you are in this country. And we're averaging on our plan for the last 14 years, less than 1% a year. You look at all the surveys. So, but back to your question, are there some economies of scale? Yeah, I think we can certainly look at some of these things. But I know that on some contracts, because we're a little bit smaller, we pay a little bit higher administrative fee now. But at the same time, we have a different. Back to Dr. Mackey's comment, as far as benefits and all, there are some subtle differences in the benefit packages, and because we're paid out of two different funds, there's times where the general fund, in my history, I've been doing this for almost, 39 years. I've seen the general fund struggle where the educational trust fund may have had some money, and if the benefits had been the same, it would have been really tough for, our fund to have made it. Answer your question. Yes, there are some economies of scale. I don't think you're going to find that it's that large, because if you saw on the charts, and of course PHIP's put numbers out there, what we pay in administrative fees is really, really very, very low in the grand scheme of things. So, but could you squeak out, $1 million here, $1 million there? Yes, but at the same time, we're spending, like, what, 1.4 billion, and we're at almost 500 million. So it's not going to be earth-shattering.
Okay, good comments. Any other comments? I would, now I know I could go back through the slides and get this, but y'all have this top of your head. What's the, is there a difference in cost of the employee? SEIB, what does the employee pay? And PHIP, what do they pay? What's the difference there? And then the other question is, why the difference? The other question I have is, while we're talking about different amounts, I guess should we look at what percentage of the general fund is taken into the payment of the employer contribution, and what percentage is PHIP's percentage there? And how do those correlate? If they do it all, or how they compare, I should say. I'm not sure what that would tell us, other than it may, as you mentioned, William, is the resources that may be available.
That's right.
That's there, and if we can retain parity between that, if that makes sense.
Mr. Chairman, if
Yes,
I
sir.
may, another point of clarification. I think I understand this right, William, that so state employees are state employees, and all the state employees work for a state agency. With the education employees, we do have what we call local employees. So for instance, many of the school districts might employ a number of teachers above the state matrix. It's my understanding that the state does not pay the $800. The local has to pay the $800 for that, but I may be wrong on that. I'd like to, I'm not sure. Do y'all know? Or I don't want to put somebody on the spot, but if you're a local employee, so the local's paying your salary, do they also pay your match, the local agency?
Nia, do you know that?
I think so.
So do we know that answer? We do? And that answer is?
I think so for local employees, for
Mike.
SEIB, it's a totally different board, a totally different plan. So any local, like City of Montgomery employees, if they participate in state insurance, that goes through the local government health insurance plan. They're not in this, and the locals pay the full cost of it. I believe it's the exact same way on the PHIP side. They're in the PHIP plan. There's not a separate local government plan in PHIP, but they pay the entire cost, and it's not subsidized by the state. But we might need to check it for sure to make sure for PHIP.
So my point, and that may be a very small number of people, but my thinking is that those folks, when they are employees, the local's picking up that cost. But when they become retirees, the state picks up that cost. Essentially, they come into the state number for the calculation.
And that's on the PHIP side.
On the PHIP side. I don't think that would be, there'd be a correlate to that on the state employee side. But it would change your numbers just a little bit, even and when, you know, we're talking about 0.5%, 2%. So it'd be interesting to know that.
Okay. I think it would be interesting also to know that. And I'd also think it'd be interesting as if that has any actual effect on fairness between the two plans, possibly. I see a nod, but
I mean, Mr. Chairman, we're happy to confirm that with you. And we
yeah,
can also look
if
for
you
We
would.
can also look for the impact. And as far as premiums, you had asked earlier, on page 10 of our slides, we have what the premiums are charged of our active premiums. And I can tell you that our funding from our employer contribution is about, I don't know what the percentages of the actual ETF. Would have to look at that. What is it now? 70%.
I've got a text here that makes mention dealing with PBMs and the RX cost matter of if we're doing any reviews with charges, overcharging of drugs and reimbursements on those issues, how we're dealing with some of those possibly, and are those being dealt with jointly together or separately? Do you know anything about that? I don't. I hope y'all do. So having talked about some of that, what else should we make comparisons of? And I might throw a couple of not answers, but questions on aspects. Admin cost, is there differences that's there? I know that's been floated around and talked about. Also, I would suggest we take a look and see if there is a vast difference in fairness, perceived or otherwise, between our employees as to what they're receiving as compared to the others. Now, I know in some of the charts and such that we've had, you know, surveys done about how yours is and that type thing, but has there been any people that's been moving? I'll use an example, if I might, to tell you where I think we may be headed. When we passed a bill authorizing the Department of Education to get involved with mental health matters, and the schools did the need was there, so we started hiring in the schools mental health folks. Well, the difficulty came is, where did they get the folks to hire? They got them from mental health facilities and mental health departments, and they were able to draw the trained personnel into the Department of Education from the mental health, and thus we had, to use an axe to describe it, we got less service, but we paid more for it. And we reduced the training on the mental health side, and thus we had that competition that's there. Are we doing that with our benefits packages and insurance? That's the last thing we want to do, is cause harm or difficulty and competition. While it may be healthy competition in some areas, that's not healthy competition. So I would like to have some folks looking at that in some way. Does that make any sense? Is that a fair question?
Chairman.
Yes, sir.
I had just one point of clarification. Are we just looking at SEIB and PHIP, or should we be considering the whole, the locals, the flex, the PHIP, the SEIB, the all the services that these folks offer? And specifically, are we including the locals on this?
Dorian, you have a comment there?
My suggestion will be we don't necessarily need to look at locals except to make sure that locals are paying their full cost. If the locals are paying their full cost, I don't think we need to look at that. But I do think it is important to look at both plans and the flex plans, because there could be some differences in the way, flex plans are handled between the two programs. And it could be an easier thing to tell the differences.
How do we look at those, Dorian?
Well, the flex, if I say something wrong, I'm not as familiar with PHIP as I am SEIB, so I'm sorry if I say something wrong. But flex is in the PHIP program. I mean, they're all together in the same program. SEIB has them separated. They have the SEIB, and then flex is completely separate. So to be able to compare adequately, I think we need to add in flex with SEIB so that we're actually comparing apples to apples and not a smaller cost with SEIB and a larger cost with PHIP on the same.
Yeah, and just for a point of clarification, we're talking about the budgets of the two, right? Because we have two separate budgets for
the budgets, but there is an administrative cost. So
Well,
he's talking about administrative costs. SEIB has administrative costs charged to the flex budget. PHIP's all there. If we are looking at administrative cost to administrative costs, we need to look at SEIB plus flex for state employees, administrative costs, when you're comparing that to PHIP.
No, I agree. No, I agree. I was just making sure what we're talking about is, because we do have two separate budgets with the administrative cost, and you're talking about combining into one.
Yes.
Okay.
Here's what I'd like to do, I think. Now, y'all tell me if I'm off track here, all right? But what I think I'd like to do is, first off, I want to set up a time frame to when we can get back together, all right? My suggestion on that is looking at the earliest potential is the week of September 9th. Let's try to see that week to plan on getting this body back together, all right? At that meeting, what I'd like to have is somebody reporting back on some of these questions that we've asked about. That I'd like to have, and we can look and further delineate that by email or other means if you choose. But I'd like to have different folks looking at these things maybe differently and yet interchangeably, if that makes sense, so we can find out where and what further we need to go. But I would like to begin this process by having some folks, I hate to call subcommittees, but a couple, maybe three different groups looking at a couple, three different things, and then come back together at that point to discuss and figure out where we're headed. Are y'all willing? Does that sound reasonable?
It does, Mr. Chairman, but I will make this comment and tried to highlight it a while ago that I think we got to look ourselves in the mirror too and make sure that we're doing adequately out of the general fund what the ETF is doing for PHIP on their side. I think there's a big difference there on what the state is paying between SEIB and PHIP. So I think that's something we've got to look at too.
I agree with that. I think we're on the same page on that, trying to find out what the percentage of each of those would be overall. Is my thinking. Would that give us a guide?
I mean, based on the numbers we saw today, pretty considerable difference. But we need to take a look at that. We need to be, as you know, I mean, y'all are the professionals. I mean, this is the most critical, thing that impacts not only workforce retention, but also our ability to recruit employees. So we need to make sure that we get that right.
Anybody have any clarification of what we need to look at along these lines under those guidelines we've talked about?
Thank you, Mr. Chairman. I'm sorry, I keep asking questions. I'd like to know, so a preface to this question too, so the Department of Education, our employees are part of SEIB, but it's paid for out of the Education Trust Fund. And I think there are other state agencies that are the same way. I'd like to know of these 31,000 employees, how many actually come out of the Education Trust Fund? I think it's going to be well over 1,000. It's not going to be the majority by any means, but it'd be nice to know how many.
I think we need to do a good point. You already know that? No, okay.
It's easy to get.
So what have we come to a conclusion then of what we're going to look at? Let's identify that. We're going to look at administrative cost, number one. Number two, we're going to look at cost per member,
Flex plans
flex plans included, of course.
and the state's budgetary support, both.
And services. By that I mean coverages. What else was there?
I had premium differences, benefit differences, percentage of general fund, administrative costs, fairness as the employee perceives the benefits, combining the flex and the SCIB, education employees in SCIB, basic per member per month expenses.
So how many topics does that count to?
1, 2, 3, 4, 5, 6, 7, 8.
8. How many members we got on this board? 12. 13, okay. How do you want to divide that up?
I mean, all this information, I mean, we got all this information, so it's.
I don't know if this is something you want us to pull together and circulate to you before our next meeting.
What
or
if
present
Joe
at
and
the
I
next
work
meeting?
together, pull all this together, and then disseminate it out, and then y'all decide how you want to possibly break up at that point?
I think that's not a bad idea. Y'all, how about y'all? All right. So we got the idea. We got those items identified. We're going to get the data together, and then you're going to circulate it to all the members, correct? And then we'll be ready to further discuss on the week of the 9th. Any particular day better for y'all in that week?
I can make it.
9th is good. That's a Monday. Okay, we'll set it for the 9th. Morning or afternoon? Afternoon? After the nap? Yeah, 1:30. All right. Now, I would encourage y'all, if you would, get the data as soon as you can, circulate to us. Now, who's going to circulate and who's got the information to circulate?
Well, we both have it,
We've
so.
got the email, so we can circulate, and if you want to, we can just put it all together in one PDF.
Make sure Asia gets everything, okay? And make sure it all, and Asia, you make the final cut to make sure everybody gets everything, all right? I would encourage everyone, as soon as you get that, to acknowledge to Asia that you got it, and then let's start talking amongst ourselves on what we see. Let's start making phone calls to each other or emails to discuss where and what our concerns are and what direction we ought to do from there. So that when we get back on the 9th, maybe we'll have a better, clearer picture at least of what's a problem and what isn't. And then we can address it from there. Does that sound fair? Anything else we need to talk about? Mr. Chairman, you got anything else? You happy with what we got?
Don't think we may want to do, if we are going to talk among ourselves as a committee of what concerns we have, let's go ahead and articulate them back to SCIB and PHIP so they'll be prepared when we come back together.
Good point. Good point. Yep. Communication, being together, let's make sure we emphasize that. Remember, no shovels or picks. Any other questions or comments? Thank you all for coming. Thanks for your input. We'll stand adjourned till September 9th.